السلام عليكم. مساء الخير. طبعا احنا النهارده we have gathered Assalamu alaikum. مساء الخير. It's a great pleasure for me to be here together with my dear colleagues, Dr. Khalid Riz, and my dear colleague and relative, okay, Professor Susan, and of course in this great meeting that has been put forward by Mina Farm. طبعا مينا فارم دايما معودانا إلا احنا نتقابل على علم على scientific background together with the introduction of new medications and new ways of treating our patients. بنشكر بالنيابة عن الدكتورة سوزان والدكتور خالد رزق نشكر مينا فارم على التجمع الجميل ده وطبعا نرحب بزملائنا الأساتذة وزملائنا الدكاترة اللي موجودين هنا معانا النهاردة. It's a great pleasure for us that you have attended this meeting. And of course today we will be going into very important grounds. احنا عارفين طبعا that pain is the number one complaint that we have from our patients. As soon as we go into the clinic, our patients are complaining from pain, from whatever autoimmune rheumatic disease or musculoskeletal disease. فالنهارده إن شاء الله عندنا program جميل جدا. The topic of this meeting is mastering pain in osteoarthritis and musculoskeletal diseases, a rheumatology-orthopaedics perspective. Of course, we have our orthopedic doctor here, but of course, rheumatologists always want to start first. So I'm going to give the go-ahead, and afterwards you will continue, Dr. Khalid. And Dr. Susan will, of course, give us the question and answer and the conclusions.
Okay. من ناحيتي برضو I want to thank Mina Farm for bringing us together in this nice place to enjoy some nice scientific knowledge today. And of course, as Anna just said, that the number one symptom worldwide is pain, and a lot of the times it is also accompanied by inflammation. So we're going to be tackling these two issues, and of course they're going to be talking about the most common musculoskeletal disorder worldwide, which is osteoarthritis. The WHO has repeatedly said that we have, like COVID-19, an epidemic or even pandemic of osteoarthritis, for two main reasons. Because the major risk factor for getting osteoarthritis is age, and the populations worldwide are increasing in age. So because of increase in age, and because of the second or bad thing about osteoarthritis is that it is closely related to body mass index, and the number of overweight and obese individuals worldwide is also increasing. Okay. So for these two reasons, we have an increase in the incidence of osteoarthritis, which is probably the worst disease that you see. Anna says, whenever I see a patient with osteoarthritis coming in through the door, I want to go out through the window, because there is no cure for osteoarthritis, and we just try to get their pain away and the inflammation in whatever way we can. And of course, what is wonderful about this meeting today is that we have this very nice collaboration between the rheumatologists and the orthopedics. So this orthopedics rheumatology collaboration is very important, because most of our patients eventually land up on your side, Dr. Khalid. So it's a pleasure that you're with us. I know Dr. Abdallah excused himself because he had something, but we have just as good a speaker and even better in the name of Khalid. Okay, so Anna, go ahead and give us your lecture on best practice.
Okay, so I've mentioned the topic, and I thought of this topic, best practice in management of pain and inflammation in musculoskeletal diseases and beyond. النهارده إن شاء الله our goals will be to understand the pain mechanisms very quickly in osteoarthritis and musculoskeletal disorders. We are going to explore the unique rheumatology's approach to pain. Of course, we have to highlight the collaboration that we have with our orthopedic doctors, and of course, we're going to end up by looking at the role of etoricoxib as an important non-steroidal anti-inflammatory drug. في البداية طبعا some numbers are very important to all of us. The prevalence of chronic pain, we know that more than 1.5 billion patients worldwide, and this is increasing every day, suffer from chronic pain. It affects more than 100 million individuals in any one nation, and it's more so than diabetes, and we know how important we have the diabetes numbers in Egypt, more important than heart disease, and more important than cancer combined. And at the same time, we know that the cost of chronic pain is heavy. The total annual cost of healthcare due to pain ranges in millions of Egyptian pounds. And of course, this includes not only the medical costs of pain care, but the economic costs that are related to the disability. If the patient has pain, he won't go to work, he won't get his wages, and that will lead to a lot of disability. Now, if we take a step back and look at pain, pain has been mentioned since the 16th century. It was the philosopher René Descartes in around about 1596. He was the first to prescribe this somatosensory pathway. He said when a nerve filament in the foot, for example, is irritated, here it's fire, it will have a burning sensation, and this burning sensation will ascend and go to the brain via this nerve filament. That was back in the 16th century. But this was wrong thinking. It's not so simple. It's not such a simple pathway. Now we know that pain is a complex set of neural, humoral, and emotional events. It includes the release of not only noxious mediators and inflammatory mediators, but also there is, in addition to inflammation, peripheral and central sensitization and remodeling of the synaptic contacts. So pain is not a simple process. And that is why in 2020, the International Association for the Study of Pain redefined pain. So if we ask our postgraduate students, what is the definition of pain? It's an unpleasant sensory and emotional experience associated with or resembling that associated with the actual or potential tissue damage. So from the 16th century, which is just one way to the brain, and that's how we feel it, now we know in the 21st century that we have ascending, bottom-up information going, as well as descending modulation of the pain, involving many, many factors, not only somatosensory single pathway. Just very quickly, I know no one wants to go into physiology at this time of the day. Just to remind ourselves of the pain pathways, we've got the first order neuron, which is the cell body in the dorsal root ganglion, the second order neuron in the dorsal horn of the spinal cord, and of course the third order neuron, which is in the postcentral gyrus in the internal capsule. Again, all of us in the room have to know that there are types of pain. Different types of pain. Because if you don't know the type of the pain and you give, for example, in norsoplastic pain, you give her a non-steroidal, that won't help her. So you have to first define the type of pain in your patient. Is it nociceptive, neuropathic, or norsiplastic? And more importantly, Is it a mixture of both? Then you have to treat each one. So we know that nociceptive pain is pain that arises from actual or threatened damage to the non-neural tissue, and it's due to the activation of the nociceptors. For example, the pain of osteoarthritis, the pain of rheumatoid arthritis. Neuropathic pain is caused by a lesion or a disease of the somatosensory nervous system, and the nociplastic pain is pain that arises from the altered nociception despite no clear evidence. There's no clear evidence of tissue damage. You look at the patient and you look at the CRP, ESR, it's all normal. There's no inflammation, but the patient has pain. This is what we call central sensitization pain, or very commonly all over the social media. Everyone is coming up and saying fibromyalgia, what is fibromyalgia? And there's a big buzz. I think they are overdoing it on the social media anyway. So just again, to put things into perspective, nociceptive pain, activation of the nociceptors by tissue damage or inflammation. What does the patient come saying? I've got localized pain, aching pain, and what are the examples? Osteoarthritis, tendinitis, and post-surgical pain. Neuropathic pain, there is damage or dysfunction to the peripheral or central nerves. Here the patient will say, I've got shooting pain, numbness, electrical-like pain, as we see in diabetic neuropathy and post-herpetic neuralgia or radiculopathy. And the central sensitization, where we have amplification of pain signaling in the central nervous system. And of course, this is where the patient comes to you and says, I feel pain everywhere in my body. Jismi kullu biwjani. You look for a cause, there is no cause. This is what we call chronic sensitization or chronic widespread pain or fibromyalgia. فمهم احنا نعرف من البداية what is the type of pain so that you can treat properly. As I said, osteoarthritis is an exact example of the prototypic rheumatic muscle disease, where we have nociceptive pain due to inflammation, due to tissue damage. Rheumatoid arthritis, bardu, it's a nociceptive pain. Here is where non-steroidal anti-inflammatory drugs can act very, very nicely. I'm just going to take you back looking at how chronic pain is increasing. And why is it? As Professor Susan said, because we have an aging population that is increasing, rising rates of obesity, more and more cultural factors come into play, greater awareness of pain among the community, rising rates of sedentary lifestyle, and of course, we have a lot of outpatient surgical procedures. The burden of pain is very important, and we see it in our clinics. The patient comes and she says, I have got pain, so much so that we say that pain is the 5th vital sign. It's so important because, as you see, it affects all the person, all the quality of life. And now we know that quality of life is so important. And here is where the non-steroidals will play a key role in controlling the pain and the stiffness in our patients. So we have to, from the outset, agree that musculoskeletal pain is the commonest cause of disability around the world. And the WHO has acknowledged this. And they say it's the leading contributor to disability worldwide, with low back pain being the single leading cause of disability around the world. And of course, these are diseases that can occur in any age, but more so in the elderly. And between 1 in 3 and 1 in 5 people live with such a condition. So these are very common conditions affecting the quality of life. So, some facts to keep in mind. Joint diseases account for more than half of all the chronic conditions in patients aged 60 or above. Back pain and arthritis are the commonest cause of chronic pain. And musculoskeletal diseases is the second most common reason for an individual to go to a doctor. And, as I said again, and I reiterate, the burden is great. Musculoskeletal disorders are the commonest cause of severe long-term disability. And you have to have a family member with such a condition to really know how it does affect it. The figures are very, very frightening. It affects 1 in 5 adults. By the year 2030, 1 in 4. And joint diseases will comprise 50% of all the conditions that we see in the elderly. And as you see, musculoskeletal conditions including common conditions such as RA and OA, have a very negative impact on the quality of life more than any other chronic condition. More so, pain can affect mortality. Survival rates among those reporting severe chronic pain are significantly lower than those that don't have pain. So pain is not just a symptom that we should take lightly. When your patient comes in complaining of pain, you should look closely at the cause of pain, because as you see, the all-cause mortality is very, very high. And as I said, the numbers are frightening. In millions do people suffer. More than 400 million people suffer from arthritis around the world. 50% of those who have chronic pain will also have depression. And up to 80% of depressed patients present with painful conditions, including musculoskeletal pain. It's a vicious circle. Many studies have shown that over 2/3 of people suffering from depression also complain of pain. UK studies show similar figures. Here in Egypt as well, we have shown that it's estimated that about 64% of patients with osteoarthritis are also found to have associated depression. So this is a vicious circle. And of course, the figures, I can go on forever showing you how depressing these figures are. Up to 40% worldwide of people over the age of 70 will suffer from osteoarthritis of the knee. And I think these values are going to increase. And this is more so commonly among the elderly. And what is very, very important is the national impact of this disease. It accounts for more than 131 million patient visits annually in Egypt, and worth millions of Egyptian pounds. People pay out of their pocket because of the pain, and they are looking for a solution of the pain. And that is why the benefits of pain control are so important in arthritis. As you see, overall quality of life improves, sleep improves, you get less load on your resources. Now, of course, when we look at pain management and non-steroidals, which is our topic today mainly, we know that non-steroidal anti-inflammatory drugs are the most widely prescribed drugs in the world. If I take a show of hands, in the last clinic that you had yesterday or 2 days ago, who did not prescribe a non-steroidal anti-inflammatory drug? All of us did. To how many patients did you prescribe it? More than 5, more than 10, or more than 15? So who's more than 5? More than 10? More than 15? You're not writing non-steroidals? You're all surgeons? You're all orthopedic doctors? I think we all write it, but we're sometimes afraid to show the show of hands. We all write non-steroidal anti-inflammatory drugs. And we all know the benefit of these drugs. We see it in our patients. They are derived from the anti-inflammatory and the analgesic effect. But at the same time, يجي العيان يقول لك ما تكتبليش مسكن يا دكتور، أنا مش عايزة مسكنات. Because they know they have side effects, GIT side effects, renal side effects. So we have to control pain. We have to know how to control it in a cost-effective method and in a benefit-risk ratio. فده مهم قوي. If your patient has pain, he does need a non-steroidal anti-inflammatory drug, you should prescribe it to him. But you should have certain rules in prescribing. And we know that over the years, we have proceeded, and we have now, in the 2000s, from the non-selective non-steroidals that were available in the early 90s, now we have the COX-2 selective drugs that have been developed, and they have increased the use of non-steroidals, as we will see as we go along. So we have to agree that oral non-steroidals are the most common drug that we used for inflammation and for pain. They do not come without risks. There are risks. And many a time you need to use them, because we can't sometimes keep our patient on paracetamol because paracetamol is too weak. And at the same time, it also has side effects. If we quickly look at the GI side effects with non-steroidals, أعتقد ده يهمنا كلنا. We should, of course, agree that we all prescribe them. And why are we writing such large numbers of prescriptions? Because, as we said, our population is increasing. More people have osteoarthritis. These are highly effective drugs. ما نقدرش ننكر إلا drugs دي بتفيدنا بيسكتوا الألم وبيهدوا الالتهاب. They contribute crucially to the management of many of our diseases, and we prescribe them on a daily basis in any clinic. More than 20 prescriptions are related to non-steroidal anti-inflammatory drugs. But we know, and this is data coming from Egypt, in Egypt, the number of physician orders that include non-steroidal is estimated to be 30 million per year. Nevertheless, the use is limited by the side effects, as we all know, and the main side effect is from the GIT tract. And of course, we always think about peptic ulcer, but don't forget that non-steroidals can also target the lower GIT tract, and that can be a big problem when you start getting bleeding per rectum due to overuse of the non-steroidals. These are some figures that actually, when we look at them, we feel quite afraid, because we know that 20% of chronic users can get an ulcer, 2% of chronic users can get a serious side effect and be hospitalized, and more than 90% of prescriptions that we are writing are to the elderly population. So we have to be very, very aware. Because while we have analgesic and anti-inflammatory benefits, we know that we can get GIT toxicity. And the magnitude of these toxicity are very large, and many of our patients sometimes end up hospitalized. And this can be a big problem, because the consequences are very important. What happens is you get your patient switching from one non-steroidal to another. And then we go into what we see here, the adverse GIT events. Up to 50% of our patients get dyspepsia, 1.5% GIT bleeding within the first year, 5 times increase in the risk of bleeding ulcers, and 30% of our patients may get ulcers. So you have to have an important strategy when you are prescribing the non-steroidals. What are some strategies to reduce the risk? Of course, we always give proton pump inhibitors or H2 blockers. We always have to make sure that our patient does not have H. pylori. So if your patient has H. pylori, don't give a non-steroidal until you eradicate the H. pylori. And what is another important strategy? You use a selective COX-2 inhibitor. So how did this come about? Actually, this guy, Sir John Vane, was awarded the Nobel Prize in Medicine in 1982 for the discoveries concerning prostaglandins and the related biologically active substances. Between these 2 years, 89 and 92, he conducted many research trials, and he discovered 2 isoforms of the cyclooxygenase enzyme, COX-1 and COX-2. So he was the first one to actually discover this. And we know that non-steroidals from pharmacology are targeting this enzyme, the cyclooxygenase, COX-1 and COX-2 isoenzymes. And we know that non-steroidals are potent because by targeting this, they attack the inflammation and the pain, and they relieve the pain. And of course, they are important. If we just look how they act quickly, we will see here that we have 2 isoforms. This is physiology, but it's important. COX-1 is the normal constituent in the body. We need it for homeostasis. It's important for the gastric mucosa. It's important for gastric cytoprotection. It's important in the kidney to maintain sodium and water balance. And it's important for the platelets. COX-2 is inducible. It happens when there is injury, when there is inflammation. So it's only present if there is injury or inflammation. COX-1 is good. It's a housekeeper. So it's the constitutive one. It's what we call the housekeeping enzyme. It keeps everything in place. COX-2 is inducible. If it is stimulated, it leads to the release of prostacyclin, and prostacyclin is what brings about the inflammation and brings about the vasodilation and the antiplatelet. So if we block COX-2 here, we will block the inflammation, so we'll get an anti-inflammatory effect, and we get a potent analgesic effect without harming the COX-1. So COX-2 acts here, and it maintains the good housekeeping COX-1. So this is the pathological, and this is the good housekeeping. And this is, as I said, the selective COX-2 inhibition, COX-2. So at the same time, this just is a repetition for us to know that when we block, if our non-steroidal is non-selective, it will block COX-1 and COX-2. So we are blocking all this here. So we are liable to get erosions, bleeding time, more kidney affection, and this is where all the problems arise. COX-2 inhibition will lead away with the bad pathological, it will decrease inflammation, improve the pain, and even they say now that non-steroidals are very good for dementia and for Alzheimer's. And that is why I said beyond musculoskeletal diseases. So this is what we should keep in mind when we think about our non-steroidals. We have in the beginning preferential COX-1 inhibitors, that was in the early 90s. Then we got non-selective COX inhibitors, including diclofenac, very strong, but very dangerous. Ibuprofen, preferential COX-2 inhibitors, including the meloxicam, and now we have the selective COX-2 inhibitors, including etoricoxib and the celecoxib. And this is a very important study that everyone should know when you are prescribing non-steroidals. It was done on more than 1,000 patients with physician-diagnosed knee osteoarthritis who had taken either a topical or an oral medication for at least 14 days. Of these patients, 54%, that's the patient that comes into your clinic and says, أنا ما تحسنتش يا دكتور، ده أنا بقيت أسوأ كمان. 54% reported inadequate pain relief. That's important because that's a failure on our side. So when we look at etoricoxib, you might say, what's the difference? What is it? It's another non-steroidal anti-inflammatory drug. Let's look at it. Let's see what is this gap. Let's look at the etoricoxib molecule. As I always tell my students, if you want to understand, go back to physiology and anatomy, and go back to pharmacology. This is the pharmacology. This is the unique structure of etoricoxib. It's got this very, very important tricyclic methyl siphone linked to the important, linked to it here. And this part, the pharmacologists looked into it because the question is, what makes it different from other traditional non-steroidals? What makes it different from other coxibs? Are we just adding another drug to the armamentarium? No. When you go back to the pharmacokinetic profile of this drug, you will see that the drug possesses certain distinctive characteristics that differentiate it from other selective COX-2 inhibitors. Number one, it's a second-generation COX-2 selective inhibitor, and it's got the highest selectivity ratio than any other COXIB. It's 106-fold selectivity for COX-2 over COX-1, compared with 7.6-fold only selectivity that we see with the celecoxib. And selectivity for COX-2 is what we want. So in addition to this, it's rapidly absorbed, completely absorbed after oral administration, and most importantly, displays dose-dependent inhibition, that's important, of COX-2 without inhibition of COX-1, and it does not inhibit gastric prostaglandin synthesis and has almost no effect on platelet function. That's important. That is what makes it unique. The selectivity, you see, big list of non-steroidals, but it's got the highest selectivity for the COX-2 versus the COX-1. And that's where you get efficacy, maximum, safety, efficacy maximum, safety maximum. Some other special aspects, 16.9 that I was told to do بوظ السلايدز بتاعتي بس أنا برضو إيه مش هتكلم. 16/9 مش هنكلم برضو. The principal route of administration is the elimination, is hepatic, دي مهمة, followed by the renal, دي مهمة. The PK, pharmacokinetic profile, is not altered significantly in patients with moderate or severe renal insufficiency, بس طبعاً it's contraindicated in patients with an estimated renal creatinine clearance أقل من 30 milliliters, and it is dose adjustments for the hepatic or the liver patients are minimal, but you cannot give it to patients having a child PERH more than 30. Another important aspect of this drug is looking again at the pharmacokinetic aspect. It's, as I said before, extensively metabolized by the CYP450 enzymes, then only followed by renal, and it has got a very long elimination, half time of 22 hours. That's why we only give it once a day. We don't need to give it more than once a day. It works almost 24 hours. So it's very suitable for once daily dosing. Our patients forget to take their drugs. And this is also important because such a drug, I think Dr. Khaled will want to use it more in acute pain. Yes, it's a candidate for acute pain because you get rapid absorption, and it's also very good in chronic pain. So it acts quickly for the acute pain to get analgesia, and for us, we can also use it for chronic pain because we get analgesia and anti-inflammation that is long-lasting. And this is all contributed to the pharmacokinetics of this unique etoricoxib molecule. As I said, half-life 22 hours, once daily dosing. As you see, again, a big list of non-steroidals. Etoricoxib has got the longest half-life of 22 hours. Also, I won't go into the details, but this drug, besides its COX-2 independent effects, has got something at the basic level. It also inhibits matrix metalloproteinase 2 and 9, and these were found to be very important pro-inflammatory mediators. So it's not only COX-2 inhibition, there is many mechanisms other than that, and this is still ongoing research. What about the therapeutic efficacy? It's good for me to stand up here and tell you that this is a good drug, but you want to use it. You want to see how good it is. So the clinical efficacy of toricoxib in the symptomatic treatment of various arthritic conditions, including RA and OA, have been studied in very well-designed trials. I'll quickly take you very quickly through the osteoarthritis. I know Dr. Khaled هيكلمنا على osteoarthritis and the pain, but as we all know, it's a common form of arthritis, and it's present in the elderly. It's one of the commonest, and it's a public health problem, and of course, it leads to disability. Here is a patient that comes into your clinic. He's 54 years old. He presents with left knee pain for the past 3 months. He's a little bit on the obese side. He's got difficulty in doing his work. He works as a postal worker. No pain at rest and no interference with household activities. So you just tell him to take an ice pack and you prescribe a paracetamol. But you do an x-ray and you find that he's got osteophytes, but he says that the pain is within, it's tolerable. The acetaminophen is doing a good job, and you diagnosed him as mild OA in the left knee. You assess the degree of involvement of his left knee, and you look at the other joints, and you tell him he has to reduce weight. He has to take care, because he's a postal worker, he has to take care of his knees and the way he sits, etc. And the patient started a new activity. He says that I'm a postal worker and I have to go up and down stairs and I have to go into the tram and out of the tram. You give him advice about that. You tell him how to take care of his knees. You give him some physical therapy and muscle strengthening, and you keep him on the paracetamol. But he says no. 2 months later, the pain is continuing, and now I can't get up in the morning. I've got difficulty in walking around. This is a patient that we started on Coxitori Cox-Story 90 milligrams once daily, together with non-pharmacological advice. We tell him to continue that, and he has reported improvement in his pain and improved in his quality of life, and he feels that he is more active, and we do want to keep our patients active. So this is where we have a success story. Very similar patient here, 68-year-old woman, generalized osteoarthritis, poor compliance. She doesn't want to take her drugs such as glucosamine and chondroitin sulfate. She says, I'm taking it, I'm not seeing any response, I'm just paying out of my pocket. So you prescribe her etoricoxib 60 milligrams, especially during her flare-ups. She says that she does very well, no GIT side effects. So this is a drug that has controlled her symptoms, and she is doing very well on it because she's keeping active. Always in combination with the other non-pharmacological. Weight loss, strengthening of the muscles, and physical therapy. Also topical. التوبيكال دي مهمة جدا 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 ويمكن منها فارم أعطت لنا يعني a very important option اللي هو inflamofen topical Diclac 3% foam. Topical treatments are quite helpful in some of our patients. So this is an option that we also have. Keep it in mind because it does help our patients. So always prescribe your treatment according to the patient you have in front of you, according to the age, and always, as I say, prescribe the lowest dose for the shortest amount of time. Very quickly, I'm going to run you through some of these very important trials. I'm not going to go into any details, but in the case of osteoarthritis, we have many randomized controlled trials or active controlled trials assessing the efficacy of etoricoxib in the symptomatic treatment of osteoarthritis. This is the dose that we have. We don't have the 30 milligrams in Egypt. We have the 60 and the 90 milligrams. And here they tested etoricoxib 60 milligrams once daily versus the very strong diclofenac 3 times daily, and also versus the naproxen, very strong, twice daily, in a very large number of patients. As you see, the red is the etoricoxib, 60 milligrams, and the green is the diclofenac. You see here that when you look at the pain scores in our patients, etoricoxib provided effective and sustained pain relief, very, very similar to the potent diclofenac without the side effects of the GIT. So that's important. Also, it reduces the stiffness. The green is the diclofenac, the red is the etoricoxib. Very, very similar, reduces the stiffness in your joints. Also, it improves the mobility. Again, very, very similar between the potent diclofenac and the etoricoxib, so very efficacious drug. Also, relieve the pain, very similar to the diclofenac initial dose. As you see, the pain was very, very much relieved in both without the side effects. And what is important is that we have with the etoricoxib more people telling us that we have an excellent response when we compare it to the diclofenac. So more people are getting a greater response with no side effects if you take care of your patients. And also, this is ongoing. You can go up to 6 weeks. The effect lasts for a long period. Here they compared etoricoxib 60 milligrams to another very potent non-steroidal, naproxen. Again, 60 milligrams, placebo and naproxen. And again, they looked at the pain, physical function, and the activity scores. And again, as you see, the red is the etoricoxib, the yellow is the naproxen. Of course, the gray, which is very bad, is the placebo. Very nice effects across the board in function, stiffness, as well as their daily activity measures. Also, compared to naproxen, improved the mobility and the performance. Again, as you see, very, very similar to the very potent naproxen with the GI side effects. So very similar to high-dose diclofenac 3 times daily, or very similar to high-dose naproxen twice daily. Quickly, at rheumatoid arthritis, we know that now in rheumatoid arthritis, we've got these very potent biological agents. Everyone is taking disease-modifying drugs. Everyone is taking biologics. But Despite advances with biologics, research has suggested that RA patients continue to experience significant levels of pain, even if they are taking biologics, because they need anti-inflammatory drugs such as non-steroidals. So non-steroidals are important because pain is important in rheumatoid arthritis. Again, they compared etoricoxib versus naproxen in a US study and in a European study. Very quickly, I'm just going to take you through it. Etoricoxib was superior to naproxen in the US study, very similar in the international study, because they used other standard of care drugs. But besides that point, we find that etoricoxib gave very, very similar results to the naproxen when used for rheumatoid arthritis. It improved the number of swollen joints, it improved the number of tender joints, and also it improved the pain across the board. And it was also very good when they compared it over a long period of time, so the patients can stay on it. And also when they looked at the global assessment of disease activity, very similar results between etoricoxib and naproxen. Also, very improvement in the amount of people getting response in the ACR 20. And of course here we had significantly fewer discontinuations, because when the patients are using a drug that gets side effects, they discontinue it. So here, as you see, in the etoricoxib, there were less discontinuation of the drug. يبقى العيان هيكمل على الأدوية عشان ما جالوش أي مضاعفات. Lots of studies have been done. I'm not going to take your time looking up at the studies. They evaluate the 2 doses. Sometimes the question comes from the audience, should I use the 60 milligrams? Should I use the 90 milligrams? Actually, between the 2 doses, there is no difference. They both relieve the pain. You have to choose for your patients. And this was a study showing you that here he gave his patients biological agents for rheumatoid arthritis, but those patients that took a COX-2 inhibitor such as Coxtori or etoricoxib, they improved more than the patients that were just on the biologics. So this supports the use of non-steroidals even in our patients that are taking biologics. And this is a patient that comes into the clinic, elderly woman, moderate RA. She's been previously on naproxen for her arthritis, but she says, I'm not going to take it. I've got severe GIT discomfort, diarrhea, and I almost got an ulcer, and that's why I'm in severe pain. We switched her to etoricoxib 90 milligrams per day. Over 20 weeks, significant reduction in tender and swollen joints, improved global assessments, and she's doing very, very much better, and she has tolerated her drug well. Similarly, in axial spondyloarthritis, we know that non-steroidals are the main pillar. We've got many, many other modalities, but non-steroidals are on top there. We can't do without the non-steroidals, and even in the new recommendations, they tell us we have to use the non-steroidals because our primary goal is that we have to keep our patient with a good quality of life and maintain him with a good. So we have to use the non-steroidals, and in the recommendations, and they are recommended, the COXIBs are recommended as the first-line drug treatment for AS patients with pain and stiffness. And sometimes we have to continuously give our patients non-steroidals. So we balance the cardiovascular and GIT effects by using the COX-2 inhibitors. And here they tell us, number 1, start with the non-steroidal, titrate to the maximum dose, and continue with it. If your patient is getting a response, continue. If not, then you only switch to the biologics. And this is across all. I'm not going to take your time giving you all this details, but I just want to tell you that how important it is in non-steroidals. It's a first-line therapy. Together with the physiotherapy, non-steroidals is the first-line therapy because they give us substantial relief from symptoms, including the back pain, the stiffness, and they are used by a big percentage of our patients. Many studies have looked at non-steroidals in anti-inflammatory drugs. And as you see, etoricoxib gives wonderful results in ankylosing spondylitis. And of course, as you say, as I told you before, once per day, so you don't have to give it because the elimination is 22 hours. So 90 milligrams once per day will get you to where you want to go. And even many of our studies now have shown us that if you give non-steroidal anti-inflammatory drugs, it may even act as a disease-modifying anti-rheumatic drug, and it may decrease radiographic progression. So that's important. There's still many studies against and many studies with that, but it's very, very encouraging. Just 2 words on the studies that were done. Etoricoxib in ankylosing spondylitis was compared to naproxen, 2 doses of naproxen, 1 dose of naproxen compared to 2 doses of etoricoxib. Primary endpoints, again, assessing pain, assessing the activity, assessing function, a bunch of secondary endpoints looking at the function of the patient. I'm not going to go into the details of the studies. I just want to take you to the results. Etoricoxib was superior to placebo and naproxen in reduction of the spinal pain. As you see, 2 doses of etoricoxib compared to naproxen. It was superior in the reduction of the disease activity. It was superior also in improving the function and in reducing pain. And what our patients have is night pain. بيقوموا بالليل مش قادر من الألم اللي في ظهره، لازم يقوم يتحرك. فده هنا it's improving your night pain because it's a 1 daily tablet. And a percentage of responders, as you see, is excellent in a very big percentage compared to other non-steroidals. So this is a very promising drug as well in ankylosing. This is just a patient that we all have, 43-year-old male patient. He's got AS refractory to the traditional non-steroidals. مش عاوز ياخد 3 حبايات كل يوم. He is taking an anti-TNF, but now because of financial reasons, he's off it. So we put him onto etoricoxib initiated, and after 4 weeks, he gets an excellent response, meaningful improvement in pain and function, and we can somehow delay the use of biologics in some of our patients if we don't actually need it. Chronic low back pain طبعا كلنا عندنا chronic low back pain، كلنا بنشوف حالات chronic low back pain. برضو قارنوا الاتيريكوكسيب 60 mg versus diclofenac، وبرضو the set of indices مش هدوش دماغكم بيها. These are the patients, as you see, more or less more women, more obese patients, many patients taking paracetamol and many patients taking non-steroidals. And Bardu, when they compared etoricoxib 60 mg to diclofenac, again in people having back pain, effective and sustained pain relief, and also improved disability. We know that back pain is a big problem, especially in countries such as ours, because it gets our people off work. And of course, excellent results in a very big percentage of our patients when you compare the etoricoxib to the diclofenac. Very nice results, similar reduction in patients that were bothered, very nice. Diclofenac 3 times daily gave similar results to etoricoxib 60 mg once daily with less side effects, and improvement was sustained. So these are studies that give us very nice effects. What about gout? Gout, we know, is a deposition disease. It's the only curable disease that we have. بس للأسف التريتمنت عندنا مش كويس because many of our patients مش عاوزين ياخدوا الأدوية. What about non-steroidals in gout? Definitely, it's the first line. Together with the colchicine, لازم ندي low dose non-steroidal as well as sometimes low dose steroids. طبعا studies have shown that it's very effective. Etoricoxib was used in 120 milligrams, and it showed excellent efficacy to people taking diclofenac 3 to 4 times daily. Gout gives very severe pain. This is a similar patient. He's got recurrent gout attacks. He was given etoricoxib coxtori 120 milligrams once daily for 8 days, rapid relief. The patient gets much better, no GI effects, and of course we get safety more. What about Dr. Khaled هيدور هيشوف what about my patients? Yes, it's also been studied in patients having post-operative pain compared to celecoxib and placebo. برضو لقوا very nice effects when we took once daily etoricoxib versus celecoxib 400 milligrams for acute post-operative pain, and it produced very effective analgesia, and especially in patients having acute pain. Also, after post-surgery, post-hip replacement, comparing etoricoxib with other drugs such as naproxen, Bardu, very nice results were obtained. I'll take you immediately to the results. Etoricoxib 120 provided analgesia in post-surgery superior to placebo and very similar to a very large dose of naproxen. ودي ده طبعا في ستاديز كتيرة أنا مش هدخل فيها بتتكلم برضو على ال post-operative pain the use of etoricoxib. So efficacy is definite there. I've showed you. You might say, what about safety? You're telling us that it's a COX-2 inhibitor. What is the safety? There was a very, very, very big trial called the MEDAL trial, multinational etoricoxib and diclofenac arthritis long-term outcome, done on 35,000 patients having osteoarthritis and rheumatoid arthritis and followed up. The primary endpoint was thrombotic cardiovascular events, and they also looked at the GIT events. What was the aim? To assess upper GI outcomes in a clinical setting. أنا بدي الأدوية real life over a long period. إيه اللي بيحصل في الكارديوفاسكولار manifestations لو في more myocardial infarction كان مرة يعني بيقولوا COX-2 inhibitors ممكن تعمل أكتر. لا اتضح اللي هو the risk is there, but it's similar to any other non-steroidal, and we always have to choose our patients properly. And of course this was the patients were encouraged to take PPI, and of course, some patients also had cardiovascular risk factors for study D. They were encouraged to take low dose. أنا مش هتكلم كتير هو ده the end result of the studies. There were significantly fewer upper GIT clinical events across all the patients compared to diclofenac. A study D was published in the Lancet, and it showed that thrombotic cardiovascular events occurred very similar to other non-steroidals, and we have to choose our patients. Also, the GIT effect was very much safer with the etoricoxib, and long-term treatment was very, very good. You can get a fracture at any time. Okay. What about geriatrics? احنا عمالين نقول geriatrics. So can we use this drug? Yes, it's equally well used in the elderly individuals. No dose adjustment if your patient does not have any problem. This was also proven in many, many studies showing that etoricoxib improves osteoarthritis in the elderly as well. But we can't give it to children. They have to be above the age of 16. As I said, hepatic, don't give it if there is a severe hepatic failure. Always adjust for the kidney. Do not give it if there is congestive heart failure. And of course, if you have an asthmatic patient, you have to take care. Is it cost effective? Yes, it is cost effective. You are using the drug to relieve the pain. You are getting efficacy. You are getting the safety. So it's cost effective. This table just summarizes how nicely it acts across the board. It works rapidly, completely absorbed, very suitable once daily dosing, greater COX-2 selectivity than any other COXIB, and less interference with aspirin, because sometimes we need to give aspirin. These are the indications, as I told you, osteoarthritis, ankylosing, acute gout, rheumatoid arthritis, improving across the board. And of course, compared to others, I've showed you the studies. What about when we compare this drug to biologics? We know that biologics are more expensive, but of course, etoricoxib acts rapidly and it acts quickly. And I want to conclude by saying that it is a good, powerful drug. It's once daily, it's present all around the world, it's becoming one of the leading drugs, but we always have to choose the lowest needed dose, not the lowest possible dose. Choose the pain relief with the lowest possible toxicity. Always consider the benefits. Do not forget non-pharmacological therapies, which are very important. And of course, احنا النهارده موجودين هنا مع orthopedic specialists and orthopedic doctors, because we need to work together. We can't do it alone. We need each other, and we need to work as a multidisciplinary care. So my take-home message is, as with all non-steroidals, the potential GI and cardiovascular risks of treatment should be weighed against the side effects, but now we know how this drug acts, and we know that we've got evidence that it does act quickly, it does act well, so we should keep it in mind, and we should always use the lowest effective dose for as shortest duration as possible. And I want to thank you for listening and for attending. Okay, so I now call upon my co-speaker, Dr. Khalid Riz. It's a pleasure for you to just wait a minute. استنى. وديني هنا. معلش هعطلك عشان انا عندي شوية الأسئلة في الآخر، خليكم مصحصحين للآخر.
السلام عليكم. السلام عليكم. بحب اشكر دكتوره أنا على المحاضره الممتازه دي صراحه. استمتعت بيها حقيقي. بحب اشكر شركه مينا فارم انها سمحت لي احضر معاكم واكون ضيف عليكم مع طبعا اساتذتي دكتوره أنا ودكتوره سوزانا. انا كنت طالب عندهم زمان على فكره. فان شاء الله نقدم توك مش هطول عليكم، يبقى توك كويس ان شاء الله نستفاد بيه. أنا خالد رزق، ليكتشر اوف اورثوبيديك سيرجي الكسندريا يونيفرسيتي في الارثروبلاست يونت. هنتكلم النهارده عن الاوستيوارثرايتس. زي ما احنا كلنا عارفين الاوستيوارثرايتس is a degenerative joint disease characterized by breakdown في الارتيكولار هالاين cartilage and proliferative changes which involve البون والsynovial membrane. زي ما احنا شايفين دي الهيلثي ني بيبقى فيها هيلثي ارتيكولار كارتلج وهيلثي ليجامنت اند هيلثي منسكاي. هنا في الاوستيوارثرايتس بيحصل بريك داون في الارتيكولار كارتلج والاكسبوز سبكوندرال بون وافكشن وايروجن وديجنريشن في المنسكاي اند اولسو في الليجامنت. الابيديميولوجي الاوستيوارثرايتس هو the most common joint disease more common in weight bearing joint اكيد في الني والهيب اكتر من الابر ليمب جوينت. مور كومن امانج الفيميل الايدج غالبا بيبقى فوق ال 60. 90% have radiological features, only 3% have symptoms. بنقسم الاوستيوارثرايتس into primary and secondary. البرايمري بيبقى دي نورمال فيسيولوجيكال بروسيس بتاعت اوف ايدجنج والتولوجي بتاعها ما لهاش نون ايتيولوجي. اما السكندري نتيجه للوكال او سيستميك فاكتورز. الريسك فاكتورز الاوستيوارثرايتس اهمهم طبعا الايدج. كل ما يزيد الايدج وكل ما يزيد الريسك ان يحصل اوستيوارثرايتس. السكس مور كومن امونج الفيميل والاوبيستي طبعا عشان بتزيد اللودنج فورس على الجوينت وعلى المنسكس فبيحصل ديجنريشن اسرع. وطبعا في جيناتيك بري ديسبوزيشن والتروما نتيجه للديلي اكسسيف يوز. بالنسبه للسكندري اوستيوارثرايتس دي بتحصل نتيجه للوكال او سيستميك فاكتورز. اهمهم طبعا هي التروما نتيجه الانترا ارتيكولار فراكشر هو ده موست كومن كوز اللي بيعمل بوست تروماتيك ارثرايتس او انجري للمينيسكس او الاي سي ال الانتيريور كروشيت ليجامنت لو اتساب ما حصلوش ريكونستراكشن. انذر فاكتورز زي congenital hip dysplasia او بيرسز ديسيز او سليبد ابر فيمورال ابيفيسيس او انفكشن زي السيبتيك ارثرايتس او انفلاميشن زي الروماتويد ارثرايتس اند اذر ديسيز. ميتابوليك زي الجاوت وهيماتولوجيك زي الهيموفيليا. ساين اند سيمبتومز اهم طبعا برزنتيشن العام بيجي لنا بيها هو البين which is related للاكتيفيتي. مورنينج ستيفنس بيبقى اقل من 20 minutes وطبعا ليميتيشن في الرينج اوف موشن. العام بيبدا يشتكي ان هو ما بقاش عارف يصلي ما بقاش عارف يطلع السلالم ينزل السلالم يعمل الديلي اكتيفيتي بتاعته وريكارنت سويلنج. بالنسبه للساينز هنلاقي ممكن يحصل فيه جوينت انستابيليتي بوني انلارجمنت عشان الاوستيوفايت ممكن ديفورميتي في الحالات الادفانسد ممكن يحصل شورتنينج يحصل فارس ديفورميتي restricted movement and some cryptus اثناء الاكزامينيشن. بالنسبه لعيان الاوستيوارثرايتس لما عيان يبعت لي مثلا اشعه ويقول لي يا دكتور قول لي العلاج لو سمحت مفيش حاجه اسمها كده. لازم اشوف العيان ونكشف عليه لان اهم من الاشعه ان احنا نشوف الفانكشنال سكور بتاع العيان ده ومن خلاله بنحدد طريقه العلاج المناسبه. نمشي معاه ميديكال تريتمنت لا محتاج انجكشن مثلا او محتاج انترفنشن. فمهم ان الفانكشنال سكور اللي عندنا الباركر سكور. الباركر سكور دوت بيعتمد على ووكينج ابيليتي بتاعت العيان inside house outside house and able to go for shopping or restaurant or visit his family. لو no difficulty at all بياخد grade 3. لو alone with assisted device 2. لو walking with help for another person grade 1. not at all grade 0. وبنجمع السكور ده اللوست طبعا اللوست موبيليتي هو جريد 0 الهايست موبيليتي هو جريد 9. another سكور هو الومك اوستيوارثرايتس اندكس. ده سكور ويسترن اونتاريو اند ماكمستر يونيفرسيتي ارثرايتس اندكس بيأسس ده عباره عن كويتشنير العيان بيجاوب عليه من 24 ايتمز متقسمين into 3 categories: البين 5 items، الستيفنس 2 items، والفيزيكال فانكشن 17 items. عباره عن كويتشنير العيان بيجاوب عليه خلال 48 ساعه اللي فاتوا، بنساله اسئله بيجاوب عليها نون سلايت مودريت سيفير او اكستريم، ده 0 1 2 3 4. بالنسبه للبين مثلا اثناء الووكينج، اثناء الستير كلايمبنج، اثناء النوكتورنال بين، ريست او ويب بيرنج. الستيفنس لو عنده مورنينج ستيفنس، لو عنده ستيفنس ديورنج ديلي اكتيفيتي. وبالنسبه للفيزيكال فانكشن هم 17 ايتم، تشمل ايتمز كتير جدا، من ضمنها اللي اسندنج ستيرز، ديسندنج ستيرز، جو سلايد اكتيفيتيز، اكستريم اكتيفيتيز. السكور بتاعنا دوت بيتقسم 0 طبعا هو ده احسن حاجه، وال 96 دوت الورست. في اللابراتوري انفستيجيشن بالنسبه لنا مفيش حاجه بس بجنومونيك خالص. الاوستيوارثرايتس هعملها بس لو انا شاكك، لو في حاجه سكندري اوستيوارثرايتس زي الجاوت، زي الروماتويد، الكلام ده كله. الراديولوجيكال فايندنج بالنسبه لنا في الاكس راي هنعمله اكس راي ستاندنج، هنلاقي بيحصل فيه ناروينج في جوينت سبيس، اوستيوفايت فورميشن، ممكن يحصل سبكوندرال سكليروزس وسبكوندرال سيست. في راديوجرافيك جريد للاوستيوارثرايتس، كيلوجرام اند لورانس جريدنج سيستم، بيقسمها جريد 1 2 3 4 على حسب الاكس راي فايندنج. في جريد 1 بتبقى حاجه فيري مينيمال او داوتفul ايفن فيري مينيمال نارونج في جوينت سبيس. جريد 2 بيزيد النارونج في جوينت سبيس ويبدا يتكون اوستيفايد. جريد 3 النارونج بيزيد ويحصل سبكوندرال سكليروزس. جريد 4 بون اون بون. في الهيب جوينت مور كومن امونج الميل على عكس الفيميل، بيحصل فيه العيان بيشتكي من ستيفنس برضه، بين في الهيب او جروين او جلوتيال ريجون. ميكانيكال بين بيزيد مع الاكتيفيتي وبيقل مع الريست، وممكن بيبدا يشتكي من مشاكل اثناء المشي والكلام ده كله. باي فيزيكال اكزامينيشن العيان هيشتكي من انتالجيك جيت، اما اجي اشوفه هلاقي عنده انتالجيك جيت، ليميتيشن في الرينج اوف موشن بتاع الهيب اكتف وباسيف، ممكن كمان بيبقى بينفول. ممكن نلاقي في الادفانسد كيسز لمب لينس ديسكريبنس، ممكن يحصل شورتنج في اللمب ده. بالنسبه للبريفرال جوينت الهاند والفوت، احنا مش يعني احنا جراحين مش دكاتره روماتولوجي ولا الكلام ده، بس ببدا اشك لما عيني يجي لي مثلا عنده 50 سنه ومعاه جريد 4 اوستيوارثرايتس، حاجه مش ماشيه يعني، مش طبيعي ان يبقى عيني عنده 50 سنه 45 سنه ومعاه ادفانسد اوستيوارثرايتس بالمنظر ده. فعشان كده لازم ابدا اعمل اكزامينيشن لاشوف هل عنده روماتيك ديسيز، وده موست كومن. انا ايه ساعات في حالات جاي لها عشان تعمل تغيير مفصل مثلا وهو عنده 50 سنه، فجريد 4 وخلاص ده بون اون بون، لا ده واضح ان في مشكله. العيان ده ببعته للروماتولوجي عشان يشخصه ويبدا يعمل انفستيجيشن قبل العمليه. تمام. فمهم موضوع برضو الايه الاكزامينيشن. طبعا زي ما الدكتوره انا كلمتنا يعني موضوع الاستراكشر الجوينت كارتليج ده عباره عن كولاجين تايب 2، بروتيجلايكان، هيالورونيك اسيد، وجلوكوزامين، ووتر، وكوندروسايتين، مسؤول عن الريجنريشن. وده طبعا الباثوجينيس اللي بيحصل في الاوستيوارثرايتس، بيحصل ريليز للانفلاماتوري سايتوكاينز انترلوكين 1 و6 وتيومر نيكروز فاكتور اللي تنشيت السيل ديستراكشن، وبتعمل ريليز للبرين فوسفوليبيد اهمها الاركودونيك اسيد اللي بيعمل ستيميليشن لكوكس 1 و 2. الانترلوكين 1 وميتالوبروتيزيس have been found to play important role in cartilage destruction. Local growth factor, especially transforming growth factor beta, are involved in formation of osteophyte. بالنسبه للمانجمنت بتاع الاوستيوارثرايتس، احنا بنفكر في العيان دوت اللي عنده اوستيوارثرايتس نون فارماكولوجيكال وحاجات فارماكولوجيكال وحاجات اوبراتيف. بالنسبه للنون فارماكولوجيكال مهم جدا موضوع البيشنت اديوكيشن. في الامريكان اكاديمي اوف اورثوبيديك قالوا ان البيشنت اديوكيشن are recommended to improve the pain in patient with osteoarthritis. فمهم جدا موضوع البيشنت اديوكيشن دوت، ده من الفيرست لاين ان انا ابدا اتكلم مع العيان، اعرفه ازاي يقوم من على الكرسي، ازاي يقعد من على الكرسي، ازاي يصلي، ازاي يطلع السلالم، ازاي ينزل السلالم. مهم جدا، ده سترونج ايفيدنس. بالنسبه للفيزيوثيرابي والاكسرسايز والويت لوس، بعض الدكاتره مثلا احنا كجراحين بنهتم اكتر بموضوع الجراحه والكلام ده كله، بس في بعض الناس بتنصح العيانين اللي عندهم اوستيوارثرايتس انه يعمل فيزيوثيرابي والكلام ده، وناس ثانيه اجنست يروح للدكتور، لا ازاي قال لك تعمل فيزيوثيرابي والكلام ده كله، لا الكلام ده كله غلط وبتاع. لا طب بالنسبه لموضوع الفيسيو ثيرابي، طبعا المهم جدا موضوع الفيسيو ثيرابي دوت لو الاكسرسايز والموبيليتي مهمه جدا، بتحافظ على الجوينت فانكشن وبتحسن الرينج اوف موشن وسترينثن المسل وبتقلل البين. طب ابسط حاجه الاكسرسايز ممكن اقولها للعيان اندور اند اوت دور اكسرسايز، تبقى سيمبل اند افكتيف فورم اوف اكسرسايز. وبالنسبه برضه للويت ريدكشن بيحسن البين والفانكشن، مهم جدا للعيانين. طب الفارماكولوجيكال ايجنت لايك انالجيزك سواء كان اسيتامينوفين او نون ستيرويدال، توبيكال ايجنت او انترا ارتيكولار انجكشن بديفرنت ماتيريال سواء كان كورتيكوستيرويد او البي ار بي او هيالورونيك اسيد، وان كونفنشنال ميثود زي الكلوكوزامين والكوندروتين والكولاجين والكلام ده كله. طبعا الاسيتامينوفين اللي هو باراسيتامول ده حاجه وايد سبريد يوزد وهو ده الموست سيف والكلام ده كله، مشكلته بس ان هو ويك شويه. النون ستيرويدال الامريكان اكاديمي ابروفد النون ستيرويدال هي ذا فيرست تشويس في علاج الفلير اوف اوستيوارثرايتس، وبتحسن طبعا البيشنت فانكشن والبين والكلام ده كله. مشكلتها بس لازم اظبطها على حسب الايدج بتاع العيان والكارديو فاسكولار اند جي اي تي اند رينال سيفتي، ولكنهم لقوا ان الاورال ستيرويدال ريكومندد تو امبروف بين اند فانكشن وده سترونج ايفيدنس. طبعا النون ستيرويدال فيها طبعا زي ما الدكتوره انا قالت لنا سيلكتيف ونون سيلكتيف والفرق بينهم والكلام ده كله مش هنعيده تاني. انا بس كنت جايب ما شفتش البرزنتيشن بتاعت حضرتك، فكنت جايب بس بيبر بتقارن بين السيلكتيف والنون سيلكتيف عشان في بعض الناس برضو مش مقتنعه بموضوع اللي هو السيلكتيف ده ان هو الافيكاسي بتاعته. فبيبرز ديت من 2012 يعني حاجه قديمه مش جديده. قالوا طبعا ان الكوكس 2 انهبيتور ايكوالي افكتيف للنون سيلكتيف، وليها طبعا جي اي تي توكسيسيتي بتاعتها اقل شويه، ولكن طبعا ما فيش حاجه سيف. النون ستيرويدال برضه بتزيد الريسك ان يحصل كارديو فاسكولار وهايبر تنشن لور ليمب اديما، والحاجات دي كلها عامه بتبقى دوز ريليتد. توبيكال ايجنت لعلاج الاوستيوارثرايتس احنا بيبقى عندنا خلاف شويه في الجراحه برضه من شخص لاخر، يعني في ناس مقتنعه بموضوع التوبيكال ايجنت الكريمات والجل والكلام ده كله، في ناس ثانيه معترضه على الكلام ده تقول ما فيش اي حاجه من الحاجات دي. طب الامريكان اكاديمي قالت ان التوبيكال ايجنت should be used to improve function and the quality of life for patient of osteoarthritis، وده strong evidence. فالحاجات التوبيكال الجل والكريمات والكلام ده كله بتحسن البين وبتحسن الفانكشن، الكلام ده مش كلام ايه عام يعني، ده سترونج ايفيدنس ان هو بيحسن البين والفانكشن. طب بالنسبه لللوكال هيت والكولد ابلكيشن، بعض العيانين يجي يقول لي انا بعمل دوت اعمل كمامات ميه ساقعه ولا كمامات ميه سخنه انه احسن؟ لقوا ان الاثنين سواء كانت كولد او هيت ابلكيشن بيحسن البين برضه وبيحسن الفانكشن بتاعت العيان، ومفيش اي فرق بينهم، مفيش اي فرق بين الكولد او الهيت ابلكيشن. وفي برضه الكابسيسين دوت كونتيننج توبيكال، الكابسيسين دوت ماده بيطلعوها من الفلفل الحار كده بيحطوها في كريمات، لوها بتحسن الاوستيوارثرايتس ولكنها كونتر انديكيتد في الهاند اوستيوارثرايتس عشان ما تعملش اريتيشن للاول. بالنسبه للانجكشن بنستخدم احنا انجكشن كتير عندنا في الجراحه يعني في حالات الاوستيوارثرايتس في ديفرنت ماتيريال زي الاسترويد، وطبعا دي حاجه مور افوردبل وبتعمل بين ريليف، وفي طبعا هيالورونيك اسيد. الامريكان اكاديمي بالنسبه للهيالورونيك اسيد قالوا ان الهيالورونيك اسيد انجكشن از نوت ريكومندد فور روتين يوز، يعني ما ينفعش على طول كل العين اللي يجوا اوستيوارثرايتس قال لهم لا انت تحقنه على طول هيالورونيك اسيد والكلام ده كله، ده مودريت ايفيدنس. بالنسبه للكورتيكوستيرويد لقوها انها بتعمل شورت تيرم ريليف للبين، وده برضه مودريت ايفيدنس. بالنسبه لحقن البي ار بي والبلازما اللي منتشره ده ليميتد ايفيدنس انها ممكن تحسن البين والكواليتي والفانكشن، بس ما فيش ايفيدنس عليها برضه. بالنسبه بقى للكومباوند اللي هي حاجات اللي هي مليانه جلوكوزامين وكوندروتين سلفيت والكولاجين اللي منتشر جدا الفتره دي، في امريكان كوليج اوف روماتولوجي اند ارثرايتس لقوا ان الكوندروتين سلفيت واللي معاه جلوكوزامين لقوا ان هو ريكومندد اجينست ان بيشنت ويز ني او هيب اوستيوارثرايتس، لقوا ان مفيش اي فرق في الحالات اللي اخذت الجلوكوزامين والكوندروتين سلفيت والكولاجين مع حالات البلاسيبو. وكل الاستادي اللي طالعه والكلام ده كله كل دوت معظمه بايس، لان كل دوت ليه علاقه بالفارماكولوجيكال اندستري والكلام ده كله، والكلام ده نوت ريكومندد في عيانين الارثرايتس. طبعا بالنسبه لنا كجراحه حالات الارثرايتس احنا بنهتم مينلي بالسيرجري، سواء كانت ارثروسكوبي او اوستيوتومي او توتال جوينت ريبليسمنت. فالارثروسكوبي تبقى خطوه في المايلد او مودريت اوستيوارثرايتس، ممكن نعمل للعيان منظار، بنعمل له لافاج نحسن السيمتومز، لو عنده منسكال مثلا ممكن نعمل له منستكتومي الكلام ده كله. الاوستيوتومي بنعمل هاي تيبيال اوستيوتومي عشان نقلل الويت بيرنج على الميديال جوينت ونقلل البين ونأخر شويه فكره المفصل الصناعي. طبعا في الاخر خالص في جريد 4 والعيان خلاص فيلد كل الترايلز هنضطر نعمل له جوينت ريبليسمنت. العيان ده كان 72 year old male patient، كان falling down 1 year ago وحصل له neglected fracture السبلم وللاسف ما اتعالجش واتسابه، فضل نايم في السرير السنه دي كلها وجالنا بالمنظر ده. في ريزوربشن للهيد وايروجن في الاستبلم وادفانسد ارثرايتس وفي شورتنج زي ما احنا ملاحظين، شورتنج في الليمب ده. خلاص مش هينفع نعمل له اي كونزرفتيف مانجمنت، ما كانش في حاجه قدامنا غير ان احنا نعمل له توتال هيب. عملت له توتال هيب، طبعا كان محتاج شغل شويه في الاستبلم، عملنا له امباكشن جرافتنج ورينج وسيمنتد توتال هيب. ده عيان تاني 60 year old male patient كان عنده advanced osteoarthritis bilateral زي ما احنا شايفين في الليفت سايد، هو عامل رايت سايد من سنه ونص، والليفت سايد فيها بون ديفكت بون ان بون ومعايا ليميتد فليكشن انتل 90. لو لاحظنا الفارس اللي موجود في الركبه 25 درجه نتيجه ل contracted medial collateral ligament and laxity في lateral collateral ligament. برضه كان القرار ان احنا عملنا له ما فيش اوبشن قدامنا غير توتال ني ريبليسمنت وكونسترين ده سي سي كي. سو سامري مانجمنت، اول حاجه لازم نتاكد ان البين دوت جوينت ريليتد، حاجه ليها علاقه بالارثرايتس نوت ديو تو تندينايتس او بيرسايتس او الكلام ده كله. انيشال مانجمنت نبدا بيه بيشنت اديوكيشن، ماسل سترينثنينج اكسرسايز اند فيزيوثيرابي، ويت لوس لو عين تخين او اوفر ويت لازم اشجعه، الويت لوس بيتحسنوا كتير. اسيتامينوفين فيرست لازم نجربه ان هو مور سيف، بس بيبقى ويك في الحالات المايلد، ممكن يجيب نتيجه في المودريت او الكلام ده لا. لوكال هيت او كولد ابلكيشن او توبيكال ايجنت. السكند لاين اوف تريتمنت هو نون ستيرويدال، الانترا ارتيكولار ايجنت او اوبيويد. ثيرد لاين ارثروسكوبي او اوستيوتومي او توتال جوينت ريبليسمنت. ثانك يو.
عايزين نشكرك يا دكتور خالد for that very interesting updated lecture. And now Dr. Mohammed Abbasi will talk to us about his nice products.